Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. Welcome to episode 13. In this week's episode, I had the opportunity to interview not just one, but two physician fellows specializing in endocrinology in the Department of Internal Medicine at my base hospital, Maxeke Johannesburg Academic Hospital. I'm sure when you hear endocrinology, some of the first associations you make are with common conditions such as diabetes, thyrotoxicosis, and hypothyroidism. However, just as there are many more hormones in the body, so there are plenty of conditions that endocrinologists manage in both inpatient and outpatient settings. I'm sure you'll enjoy this week's episode featuring Dr. Ruchika Mehta and Dr. Constance Adams. Whether endocrinology is a sub-spec you've considered a career in or not, it's helpful to appreciate the journey to specialization that fellows and consultants go through and the decision algorithm that guided their choices. Whereas only a few of us will become endocrinologists, we're all guaranteed to consult endocrine for an opinion at some point. Before we dive into the contents of today's episode, I'd like to give a special mention to the sponsors of the Dr. Coffee Podcast. Our first sponsor on the Dr. Coffee Podcast, I'm pleased to introduce you to FlashMed. FlashMed is a new type of medical study flashcards pre-packaged and formatted to assist you to be more effective as a student and ultimately help you to become a better doctor. Comprising pharmacology revision flashcards, clerking sheets, muscle anatomy flashcards, and revision notes, amongst others, FlashMed products are printed using the highest quality paper, and each set consists of 50 flashcards or pages. You can find FlashMed on Instagram at @FlashMedSA and order direct from them via DM with nationwide delivery. For this and other episodes, I'm also pleased and proud to announce our partnership with WardWorks. WardWorks is a free patient list and task management app that allows doctors to simplify the way they work. Join the hundreds, if not thousands, of South African doctors who are using WardWorks to keep track of and easily access patients' information, location, and ward work. There's a reason that more than 250,000 tasks have been completed using WardWorks in less than 2 years. WardWorks is a web-based app that can be accessed through your internet browser on mobile or desktop simply by visiting wardworks.app. But most convenient of all is to find the downloadable applications on the Apple App Store and Google Play Store. You'll also find some very useful perks to using WardWorks, that's PERX, such as discounts on scrubs and stethoscopes and other cool stuff that makes being a dogatella that much more rewarding. Thank you to our sponsors, and now back to today's featured specialty, endocrinology. As Dr. Adams puts it, being an endocrinologist is about being a good general physician of the whole patient, rather than just an expert in a single organ or system. I enjoyed our conversation, and I'm sure you will as well. So without any further ado, here are our guests, Dr. Ruchika Mehta and Dr. Constance Adams. Welcome to the Dr. Coffee Podcast, Dr. Ruchika Mehta and Dr. Constance Adams.
Thank you for having us.
It's wonderful to have you both on the program. It's the first time I've interviewed two guests, so I think there'll be a little bit of interplay and having to ask, okay, I'm directing this question to you, Ruchika, or I'm directing this question to you, Constance. But if you bear with us, audience, I think there will be some gold at the end of this. So the first question that I begin with in all my interviews is to ask about your medical training and where you went to medical school and then where you did your junior doctor years. So we'll start with you, Dr. Ruchika. Where did you go to medical school? And then tell us about your internship years.
Okay, so I'm a foreign medical graduate. I did my undergraduate training in the University of Nairobi, that's in Nairobi, Kenya. And I then subsequently did my internship at the Aga Khan University Hospital, which is also in Nairobi. And then I did some medical officer time there. I worked in the casualty and I worked with a physician in his sort of private practice for a bit before I moved over.
You obviously had a completely different training experience to most of our audience. What could you say was different in Kenya compared to South Africa?
So there's pros and cons of training on both sides. The pros that I think keep coming back to me is the intensity of the infectious diseases and tropical medicine we did there. That is very well taught there, which I find that there may be gaps here. And however, there's a lot of gaps I found there that, I had to sort of catch up with over here. our anesthetics training, our surgical training may not be up to par. And there are certain disciplines or rotations that if you miss, you don't get to catch up with. The way the program is designed here, though, is that everybody gets an equal chance at training in all sort of disciplines at the undergraduate level. So in a way, I got to catch up on those deficiencies during my time here.
I think at some points in the interview, I would like to also just ask you about what it was like to try and find a job in South Africa. We'll get to that. But I also want to give an opportunity to Dr. Constance to tell us about her medical training and where she did her junior years.
So, unlike Ruchika, I'm Joburg born and bred. Unfortunately, I did my undergrad at Wits.
Why unfortunately?
I think, so I did undergrad at Wits. Did my internship in Joburg as well, but I did it at a peripheral hospital. Did my ComServe as well at a level 1 hospital, so just outside the Wits circuit. I think I always knew that I'm going to end up spending most of my career at the 3 cluster hospitals. I thought, let me try and branch out. But the furthest I went was like the East Rand.
But that's interesting that you intentionally said, I want to do internship and ComServe at a lower level where maybe you're a little bit away from the academic teaching and training. Do you feel that that was a good decision and now looking back on it, and why so?
I think it was a good decision. I think the Wits circuit, it is sheltered. We have an idea that medicine is in a certain way. Once you get out into the actual world, you realize that there's not as much structure and support. A lot of people then get frustrated and then want to come back and think the system doesn't function. So doing medicine out of here, I think just taught me how to think differently, how to adapt to other situations. You don't always have that chain of command like here where there's a reg to call, there's a senior reg to call, there's a consultant to call, there's a professor to consult. You kind of have to make do with what you can, and you fight really hard to refer your patient.
Yeah.
People who train in the Wits circuit and stay in the Wits circuit, I think they get such a culture shock when they actually step out.
Wow, it's really interesting. Were there any difficulties you had with referral and, like you say, fighting for patients? Do you find that people in tertiary centers are resistant to your referrals?
I think so. It's one of the reasons I actually came back to sub-specialize, because I was like, making good connections and then maybe possibly going back to work at a peripheral hospital will just improve the referral system. I think, I'm sure it happens. Doctors, when they hear, they get a call from a peripheral hospital. If they don't have a bed, they don't have one. They don't go out of their way to make one. But if they had a patient here who's in casualty, who they faced with, they're going to go to the ward, try to discharge a patient, try and accommodate a new patient, And because doctors in peripheral hospitals maybe aren't, if they don't speak the language or present the patient in a certain way, they'll get overlooked.
Yeah,
and the patients won't actually get access to here. Wow. And a hospital like this doesn't serve the local community. It's a referral hospital.
Yeah, I'm sure there are a lot of ComServe doctors who can really identify with what you're saying. Hopefully things have changed. Hopefully they're improving, but something to take great cognizance of. So I'm going to come back to you, Ruchika, now to ask you about what it was like to try and find work in South Africa. Did you find that people were a little bit resistant to hiring you? Did you have a waiting period? Did you ever have to do supernumerary time?
Yeah. So I did my registrar training in a supernumerary post, and the biggest hurdle to that actually was, unfortunately, the registration process with HPCSA. There was a year of me waiting between submitting my documents and actually getting registration, partly because of inefficiencies in the system, losing documents. You'd mail them through, they'd get lost. So with HPCSA, there was a bit of delay in registration. So at that time, I was basically sitting at home, unemployed, and quite, frustrated because I wasn't doing much with myself. So at that point, I did consider alternative career options, but it wasn't very enticing. The idea of leaving clinical practice to go and do something in, something that needs your medical degree but is in a office setting, like or with an insurance setting, that just
but also after
did not
you've done
appeal.
10 years of training, for your medical degree, and then to struggle to find a job must have been really disappointing and frustrating.
So actually, once I did get my registration through, supernumerary posts were open. I applied to the Wits circuit, I got in, and then it was a matter of assigning a joining date. And then in July 2015, I started my registrar training in Baragwanath in the peak of winter. it was an experience of note, because other than getting used to the volume of work, having to work again after that whole gap, I had a 15-month break from work. I had to get used to the Joburg winter. It is unheard of. And Barra is particularly cold.
You're
at
exposed.
night.
If it rains, you get wet. If it's cold, you freeze.
Yes, it was something. They took a lot of getting used to. But then, once I got into the gist of things, that was it. 4 years just went past. It was difficult at times. There was even a bit of resistance to this foreign graduate who was in the system. Not all your colleagues take kindly to you initially.
Sure.
And then they all warmed up and eventually I was part of the system.
Coming to you, Dr. Constance, what did you do after internship and ComServe? Did you go straight into MO posts? Did you go into reg time? How did it go for you?
So after the 6 years at med school, I was a bit feeling stifled by the academia and just to me at the time, the pomposity of everybody. And I wanted a bit of an escape from that. Something a bit more casual, where there isn't this hierarchy between juniors and seniors. Everybody's collegial and you're being taught and mentored. And I felt like it was a bit too brisk for me. I was a medical officer for a couple of years. I still wasn't sure about what I wanted to do. My idea of being a doctor at the time was just being a doctor, which I think to me meant a general practitioner.
Okay.
The only contact I'd ever had with a doctor before was the GP with a practice in the community. So I had no idea that there's world of specialties and subspecialties out there. I didn't have any relatives who were in medicine before. So I was satisfied. So after ComServe, obviously I started seeing that, I want more. My knowledge base is limited. It's more just at a triage level. All I'm doing is referring, and I realized that, I want to do more. And then I think the natural sub-spec for me was being a physician, because it was you're still doing medicine, but you're doing it at a specialist level. So then I decided I wanted to be a physician. And then because I was, I'd say from outside a peripheral hospital, I did think I'd struggle to get in because everybody who had maybe done ComServe in the VIT circuit would be prioritized, because the assumption is that you are ambitious if you're staying and, you networking with all the right people. But then I had thought that, I need a different perspective. So then I was lucky enough to get placed as a reg after my 2 years of being an MO, and then joined the reg circuit. So obviously when I finished registrar time, again, I was satisfied. Thought I've become a physician. I've exceeded my idea of what a doctor is. But then again, because now I'm networking with everyone's a physician, realizing that, there's more to this. You specialize so that you can know everything on a deeper level, and then afterwards you want to know one thing really well and become an expert at it. So I became a physician again for a couple of years at a hospital. I enjoyed it a lot, but then I felt like, I need to think about the rest of my life. It's really hard to be a good general physician on your own because you don't know everything. And I thought, let me be good at one thing and have general knowledge as a physician, and have a network of referrals to other sub-specs. That kind of made me decide to subspecialize.
It's interesting, as I listen to you talk, it's almost like the time away from the academics made you realize the value in it, made you see that it was something that you wanted. So it was a healthy break in that sense. But also what comes through very clearly is the importance of people and relationships. Whether you're in a peripheral hospital trying to refer, or you're trying to advance your career, or you're trying to get posts, it's so important that you don't burn any bridges and that you make those connections, that you network, as you say. I found it very interesting that you said that people considered you more ambitious if you were in an academic hospital, if you were in a Barra, or you were in a Simja or a Helen Joseph. Do you think that still is the perception today?
I think my idea of that is that the hierarchy that is at academic hospitals puts a lot of the work pressure on junior doctors. So it's almost like you're paying your dues by working really hard because you make everybody's life easier. It's never an even work environment. So because of that, you paid your dues, and therefore you kind of deserve to then get another post.
I see.
You know.
I understand. Okay.
So obviously, the higher you go, I'd say, I won't say the less you do, but the more comfortable life becomes, because there's always a step ladder that you are ascending.
So coming now to endocrinology, because you're currently doing your fellow time as endocrine specialists. So this is your opportunity to advertise your specialty, what it is that makes endocrinology special, what it is that appeals to you, and maybe also to dispel some of the myths we might have about what an endocrine specialist does. So we'll start with you, Dr. Ruchika. You look like you're very eager to to tell us.
So first of all, I think I'll start by saying endocrinology is not all diabetes and thyroid. There's a lot more to it. And I also feel like sometimes I'm out of my depth in the specialty because there's a lot of things I didn't see. Even as a registrar, and even as when I was working as a general physician, there's a lot more. We do liaise a lot with the specialties outside of medicine. We work closely with neurosurgeons, with the endocrine surgeons, because a lot of our referrals do come from there, whether it's pituitary tumors, adrenal masses, also when it comes to thyroid malignancies, adrenals. So there's an overlap, and we have to work closely with the other specialties. It's a niche area where at the same time we do a lot of general medicine as well, because we have multiple endocrine systems that tend to be connected. We tend to do a lot of general medicine, and yet there's this very specialized niche area that we work in.
Dr. Constance, what can you add to that?
So for me, I find endocrine appealing because it isn't one organ. For me, being a physician has always just been about looking at the patient holistically. And I found that endocrine, because you're not focused on one organ, you have strong general medicine skills. And you're able to maybe solve some problems that other people overlook because they know everything about the heart or the kidneys or the lungs. But because you can't just find an easy pattern, you're more likely to have a more comprehensive overview of the patient, and that appeals to me with endocrine. There's much more to it than diabetes.
That's really cool. Staying with you, Dr. Constance, it seems like you have a number of patients that would be what we would call like lifelong patients. I don't know if that's true within the state sector, but certainly within private hospitals, I'm sure there's patients that will follow up with one doctor. Was that an important draw card to you, or is that something that as an endocrinologist is not particularly important?
So for me, one of the other things that drew me to endocrine is because I still enjoy the patient encounter. So, everyone kind of decides at the beginning you're going surgeon or physician, or you're going pathology, for example. I found that I do like the patient encounter. Patients want to know about their health, educating them and actually managing them. So endocrine is like that. You're likely to have a patient for life, and you walk that journey with them, which I prefer. Yeah.
Okay, so you've spoken about having a patient for a long-term relationship. I'm going to ask both of you, how frustrating is it when patients don't manage their conditions well, or when they get lost to follow up?
I'd like to start by saying that sometimes the patient is as good as your education to them. So if we've not actually educated them, taught them the risks of their condition, what are the complications, the potential complications that they will deal with one day, what are the potential side effects, then we don't expect them to know better. This is also we're not dealing with patients that have a lot of internet access, higher education, that they will go and Google all of this information. So to those patients, our primary duty is to educate them about the condition and not assume that one session of education is enough. We can have a type 1 diabetic being diagnosed at the age of 15. What do they retain at that age? Anyone with a new diagnosis has the initial shock of dealing with a chronic lifelong condition. I think repeated education is quite important. And also to break it down in small sessions in a language that they understand, touch base with them every so often, and also not blame them for not adhering to medication. Some of our patients don't take medication because it wasn't dispensed, because they can't read, they may not even be able to see the numbers on the pen. So we have to teach them how to listen to the clicks on the sounds, and also understand why a patient is not taking medication. Quite frequently, it is a side effect, and they've just not been taught to give us feedback. For example, metformin is giving you diarrhea, so they think they're intolerant to it and they stop it, but they don't know that maybe there's a way around it. So really, it is up to us to tell the patient, if the medication doesn't suit you, come back to us. If there's side effects. If you're getting hypoglycemic episodes or whatever side effect it is, you have to touch base with us for us to deal with that. So quite often we blame them when actually we didn't do our part in the first place. And secondly, we have to see, does the patient even have a social support structure? We have an old granny living on her own. She is not able to see in the dark, not able to fetch their medication. Are we doing anything to mitigate those circumstances? For patients who are in jobs, can they take the insulin to work to use it at lunchtime? There's no fridge at work. So all of these practical things, before we start to blame the patient, we have to see, did we do our part?
Wow, that's really profound. Dr. Constance?
I agree wholeheartedly. I think, the main thing is empowering the patient with health education makes a huge difference in their management, especially in endocrine. It's not necessarily remove the tumor and you're cured. A lot of it is just a lifelong chronic condition that needs the patient's input.
And endocrinology in South Africa relative to other parts of the world, is there anything that we face more than other parts of the world? Is there anything that we are particularly good at managing?
I think we see a similar spectrum. Diabetes and obesity it's a worldwide pandemic. It's not just South Africa, but we do have the context of we still considered a low-income country, but we've got Western diseases. So we've got this double burden of poverty and affluent diseases like obesity and diabetes. So we probably are suffering more than other countries with the same conditions but less resources to manage them.
More than that, I'd like to say that the numbers that we deal with may be overwhelming for a physician in a first world country, because they're used to a very limited number of patients. For example, at a specialist endocrine clinic, they may see 6 patients in any given day, and it means they have ample time to spend with the patient, which is a plus for the patient. But if they were to deal with the kind of numbers we deal with, it may be overwhelming. At any given point, sometimes we deal between 10 and 20 patients at the clinic, and that's over and above your additional duties of, seeing patients in the wards and continuing your research. So because of the kind of pattern we are used to from medical officer time, registrar time, and now, as specialist physicians or going into fellowship, we can deal with numbers, and given constraint, we can deal with growing numbers more easily than I suppose they can in more resourced areas.
So that kind of leads me to the next question: is what is the long-term kind of lifestyle like for an endocrinologist? Is that something that you chose endocrinology because you wanted to focus on family, or you wanted to be a little bit more available for weekends and things like that? Is that something that is true of endocrinology or not really?
I'd say different strokes for different folks. I personally picked endocrinology for multiple reasons. One of them being the lifestyle that it affords you. I like cardiology, but I don't see myself leading that kind of lifestyle. And similarly, by deduction, I came to endocrinology in addition to the fact that I have a passion for it, especially for diabetes and all the feedback system and hormonal pathways. But yes, it does afford you a lifestyle which doesn't involve too many emergencies. You're not likely to be called out in the middle of the night unless you're in a private practice. There is no emergency interventions involved. So yes, it is. There is a comfort that you do afford yourself by choosing this subspecialty. But in addition, it's also very rewarding because we can see immediate and long-term benefits to our patient management.
And then Constance, the next question kind of married to that is, how great a need is there for more endocrinologists in South Africa?
So I think, endocrinology for me, I think it builds up a lot on general medicine. So to be fair, endocrinology should be seeing more complex cases than what we currently are. We're actually being burdened a bit with managing run-of-the-mill diabetes and obesity, which are things that probably family physicians, general practitioners, GPs could manage, especially hypothyroidism, etc. So I think that a role of the endocrinologist should also be strengthening and supporting and helping develop GPs, family physicians in managing endocrine disorders. So they will be able to reduce our patient load and actually then focus on the more niche sub-spec endocrine patients. Yes.
Just so I understand, this is a genuine question from my heart. there's no legal hindrance to a GP managing a patient's diabetic medication, seeing them for follow-up, is there? Or is that solely the scope of an endocrinologist?
No, that I think that's the scope of a GP. If they can't manage, if a patient's becoming complicated, they're developing chronic kidney disease, they're developing things where they're not responding to usual first-line medication, and now they need someone to help them individualize care, then I think then it falls under the scope of possibly an endocrinologist. Yeah.
Sorry, and just dealing with the numbers that we have of diabetics and all the new drugs in the market, it would not be practical to hoard all the new drugs and say that endocrinologists are the only ones who should be prescribing them. And practically speaking, we have been to conferences where GPs have attended as well, and they are quite adept at prescribing the GLPs and SGLT2s. In fact, possibly more so than us, because in the state practice, these are not easily available to us, but out there in the private practice, the GPs are prescribing them more frequently, and so they're possibly more conversant with the side effects and the patient profile and the patient preferences when it comes to these drugs. So yes, so to speak, it is an endocrinologist's profile, but it's not limited to us.
So it's clear that some of the chronic conditions that endocrinologists are managing can definitely be stepped down to primary care physicians, to family medicine physicians. If somebody was interested in endocrinology, what exposure could they get to help them to determine if this is where they want to spend their career? Should they spend an elective in endocrinology? Would that be a fair reflection of endocrinology? Or is there a resource you can recommend that will give them more insight into what your day-to-day life and your academic training is like?
I think an elective is a great idea, yeah. On the surface, endocrinology isn't apparent, so spending time at the outpatient clinic is actually vital, because most of our patients, I'd say, are outpatient based. We get some, emergency admissions, but a lot of the conditions are lifelong chronic conditions that are managed as an outpatient. People won't get exposure to that by rotating in the ward, for example. It's going to have to be coming to clinic on an endocrine day, really, and seeing what the scope of our referrals are. I think is probably the best way to get an idea of what endocrine is, yeah.
The way I'd answer that is, I would say that for someone who has a special interest in endocrinology, maybe do your internal medicine time first, because that really clarifies to an individual what they like. Is endocrinology your thing or not? You may not even get to rotate through it, but you will go to the odd diabetic clinic, and you can spend some time in the endocrine clinics to see the kind of conditions we deal with, when we have the Cushing syndrome being referred, the acromegalics, the thyrotoxicosis, the hypothyroidism, the different spectrum of conditions that we deal with, then one gets an idea of whether this really interests them. We also have emerging interests such as transgender medicine that is being practiced in some of our endocrine clinics, and it's a specialty that still needs to grow. So I think to know whether or not this really excites you, spend some time in internal medicine and then evaluate that.
Interesting. I'm going to shift tack a little bit, because I'm interested in getting your personal experiences in medicine and your personality across on the podcast. So I'm going to start with you, Dr. Constance, about how the landscape of medicine is at the moment, specifically as a woman. And as a woman, you use the term women of color. I mean, I hate that we have to politicize melanin and things like that. But the reality is that our country has a past, but it also has a present and a future. What does the landscape in medicine look like? What has your experience been, and how can we be better?
Okay, so I think that in terms of human resources in healthcare in Joburg, I think there's probably are enough doctors. They're just not it's not equitably spread across all the hospitals that we need. We all want to bunch around the academic hospitals. I have a personal, kind of interest in that. There's a lot of understaffed, underdeveloped hospitals that consultants don't want to work there. Fellows, regs don't rotate through there because they don't have ties to the academic circuit. So I'm so interested in people starting to disperse to these hospitals so that we all kind of work together. COVID really improved that a bit, because then we kind of all understood that we're all in this together. We're going to have open referral systems, upward referral, downward referral. We're all working for the same government, serving the same community. So people won't be so closed off about their hospital and their resources, and we'll share.
Yeah.
When I say resources, I'm talking about mentoring and
not just actual equipment, but
giving
people.
you trips, but people. Yeah, someone's good at something. Maybe have a week where you're gonna have outreach and be the authority on a certain topic, and every hospital knows that Friday afternoons we're having a session and we're going to keep interesting patients for this doctor to see. But that only really works if we're all kind of on the same page. That's interesting to me. So I think I'm proud though of medicine. I think that across the board, men and women are treated equally. I haven't really felt any discrimination about in that way. And transformation has occurred as well from med school admissions and the registrar program in terms of equity. So I think that's been improved a lot.
It's really good to hear.
Yeah. People have opportunities. I think they just have to know that they should take them. Yeah.
Yeah. That's Ruchika.
I completely agree with Constance. I think I've not had a negative experience all along in terms of seeing that my colleagues are treating women differently. Medicine is probably very inviting to females, and males and females are actually treated equally in the system. Interestingly, both of Constance and I don't have children, but from what we've seen of our colleagues, there has been some exceptions made for females. Some have gone on earlier maternity break or had extended maternity. I agree that they're not necessarily given time off calls. In fact, sometimes before you go on maternity, you can be made a floater, which means you're probably working hard in internal medicine, picking up extra calls. And in other cases, you've been put in MOPD where you can have a break from calls. So it really depends sometimes on what situation you found yourself in. Yes, there isn't a dedicated mummy program like there is in surgery. Maybe indeed if females feel like there's a need for one of those, then the department could consider it collectively. But I don't think we are best suited to answer this question simply because we weren't faced with that scenario.
Okay, that's fair. That's fair and to the point. I love that. So we're coming towards the end of this podcast. Time is absolutely flat. It's been very interesting to have two perspectives, two shared voices, in many instances talking as one, but also to layer and color each other's perspectives. So I'm going to switch tack a bit again now to where endocrinology is going. So for somebody who wants to take a career in endocrinology, they're really going to be looking at where endocrinology is going in the next 10 to 20 years. So can you look into your crystal ball and think, how is endocrinology going to change in that time?
I think endocrinology is becoming very, I'd say, research-based. A lot of the treatment modalities we have will be more molecular, biochemical, genetic. So we'll be able to offer probably more personalized precision medicine for patients. And that's a lot of that's going to depend on an interest in research.
That's really
being
interesting.
Able to see what are the differences between people, why do they respond differently to medications, and how we can tailor their management. So it's maybe not as clinical as it might seem at the outset. It's going to end up becoming a bit more.
But that's also exciting because, as you say that, it sounds to me like that's something that there will be enough financial resources behind, because a lot of the endocrine patients are people who are going to be taking medication for their lifetime. And so it's in the pharmaceutical company's best interests to develop these drugs, and the genomics, like as you were saying, to have tailor-made precision medicine. It's really exciting because it's not just so much giving a pill and then seeing in 6 months how the pill has worked, but to tweak it and optimize it for individuals. Dr. Ruchika, anything that you can look into a crystal ball and forecast for endocrinology?
I think that there's very exciting drugs that are being researched at the moment, and it's very interesting to see that the molecules or peptides that were first discovered 35 years ago are now being turned into therapeutic targets. So I think if you watch this space, there's going to be newer drugs in the market, and some of which have unintentional but beneficial consequences. That's how the GLPs and the SGLT2s came to be, because they were trialed for one indication and found to have a benefit on another indication, and then trialed specifically for that indication. So it's very exciting to see that a lot of these niche molecules are being developed. And
with downstream things along the way. It's great. Yeah.
Yes, so possibly there'll be pharmacology textbook will probably be rewritten in the next few decades, where there'll be a lot of exciting drugs that didn't exist a few years ago.
So what are some of your favorite stories about endocrinology? I'll share mine. It's about how they first discovered insulin and went into a diabetic ward with, let's say, 24 dying kids in DKA, and went about injecting these kids with insulin, and one after another, these kids suddenly miraculously recovering. I think the way it's described is as they were reaching the last patient, the first patient was kind of waking up, Do you have any other interesting stories or anecdotes about how endocrine has changed medicine, or how endocrine can be an exciting discipline, not just long-term, but with real visible effects on people?
For me, I'd say, I've mentioned hypertension. It's commonly known now that like 10% of hypertension is caused by primary aldosteronism, which is a condition that endocrine manages. Wow. So we know it as Constance syndrome.
Yes.
Got an aldosterone-producing tumor in the adrenal. So, when you have a 35-year-old patient coming in with a hypertensive bleed, and being able to actually cure their hypertension just by doing a deep dive into the potassium levels,
yes,
measuring their aldosterone and renin, and finally proving that they've got a tumor producing aldosterone has been something that I find worthwhile, even if it means screening thousands of people for this condition, if you can cure 10% of the population with hypertension, for example.
Wow, and that alludes back to what you were saying earlier about being a good holistic physician who's going to look at things differently to somebody who's just a single organ system specialist. You look at the patient and say, how can I put this whole puzzle together? Really interesting.
In my case, I think it's an exciting spectrum for the transgender patients, because they're finally getting acknowledged, and they're finally getting access to care that they should have probably been given decades ago. But it's exciting. It's nice to see the change that you make on the impact made on one patient is quite large. This is a marginalized group in society that has been denied care, which means they also get denied access to jobs, housing, and normal relationships. So by addressing their issues, and it's actually a very large society if you look at it in terms of numbers, by addressing their healthcare needs and the stigma that they're facing, because burdened with not only with their hormonal profile is their increased risk of HIV. So they're also stigmatized when it comes to HIV clinics. So if we're able to address this and help this entire group of people, I think we're making big strides in society.
As you said, so much more than just thyroid and diabetes.
Absolutely.
So as an endocrinologist yourself, or as a fellow in endocrinology, what is something that you have changed about your lifestyle, something that you've changed about yourself, or is there anything that you say, this is one thing that I have started to do to doctor myself better?
I think for me, I'm so fearful of getting diabetes now. When I think about the burden on the patient that goes into, sometimes we demand patients check their sugars 7 times a day.
Sure.
I find it unbelievable that I prick myself 7 times a day. So one of the things, I think I'm more passionate about in prevention and health promotion, and trying to actually prevent developing these chronic conditions that are possibly avoidable. So watching sugar intake and trying to just live a healthier lifestyle. Yeah.
Dr. Ruchika, you nodded in agreement, but do you have anything else that you'd...
I think I'm just trying to push this on to patients more than on myself, because you don't understand how little patients may understand where the glycemic sources are. Some patients actually don't understand the fact that because sugar is derived from fruits is still sugar, and what actually is considered a good carbohydrate and what is not. So I find that quite interesting, that when you start having this discussion with them, it opens up a whole world of questions that they were previously unaware of. So
But Doc, I've been very good at my sugar control. I ate only pizza, no sugar.
Diabetic basmati rice.
Diabetic basmati
And
rice.
then we realize how little is actually known out there about food, something that we are eating 3 or 4 times a day, but we know so little about it.
Yeah, really interesting. Okay, now switching tack one last time. If you could pass a message on to junior doctors and medical students, something that you see in us, something that you want to amplify in us. This could be good or bad, but just your final message to young doctors in South Africa, what would that be?
I'd say don't take yourself so seriously. Your time will come. You know, the stress and the rush and the race towards specialization, giving up a lot of aspects of your normal life in order to get into an academic post. Don't look back and regret it. You know, time spent with family, time spent with loved ones, time spent doing things you love, you know, outside of medicine are equally important. Don't sacrifice everything to get into an academic post just for you to feel you rushed into it and now you feel burnt out, burdened, and you're doing something you don't actually enjoy. So step back, ask yourself what you really enjoy doing and do that.
Very good.
Yeah, I definitely agree with that. I think don't conform to what everyone else's idea is of the trajectory you should take. There isn't a timeline. Take breaks in between. If you're not yet sure about what you want to do next, then pause. Just work as a doctor. Find yourself, find your interest, and then that will shape what you eventually decide to do for the rest of your life. You won't know that at 25. You might not know that at 30. Have an outlet. So, for example, you know, retain your high school friends, retain your varsity friends that aren't in medicine, so that you've got a different perspective. There's more to life than just medicine. And if everything you're going to hear every day is about ward rounds, ward work, this and that, you might be miserable. So having hobbies outside of medicine is important. Having talks and discussions outside of medicine is important, so that you know there's more to life than medicine.
Wonderful. Thank you so much for your time. It's been an absolute privilege and honor to hear from both of you. And thank you for your valuable input into this podcast. Thank you, Dr. Ruchika.
Thank you for having
Dr.
us.
I hope you enjoyed this week's episode as much as I did. If you know of a consultant or senior registrar in a specialty that you would like to be featured on the Dr. Coffee podcast, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram and YouTube with the username @drcoffeeza. If you've got anything else on your mind, such as a request for additional topics, further information on how to engage with our guests, feedback on the show, or anything else, please get in touch. We'd love to hear from you. Thanks again to the sponsors of this week's episode, FlashMed and the WardWorks app. Don't forget to give them a follow and a like in appreciation of their support. You can find links to their social media pages and websites in the show notes for this episode. The Dr. Coffee podcast is brand new and freshly brewed each week with you in mind. Please consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy. Thank you so much for your support.